Welcome to Echocardiography lecture series. This lecture will be about LV pathologies part 1. The objectives are ischemic complications, dilated cardiomyopathy, and non-compaction. The rest of pathologies will be covered in part 2. Ischemic complications are ischemic cardiomyopathy and myocardial aneurysm, pseudoaneurysm, and intramyocardial dissection or dissecting hematoma. Now, ischemic cardiomyopathy is defined as LV systolic dysfunction with ejection fraction less than 40% that is due to coronary artery disease. And there is a few clues that will tell us this is most likely secondary to coronary artery disease. For example, you can see a bright thin wall here, which is scarred myocardium. Also, you can see that the dysfunction or the regional wall motion abnormalities, they follow a coronary artery. For example, here you can see that mid to distal LAD is involved. Not only that, also RCA is involved. So you can see here the proximal septum or infraseptum, as well as even the right ventricle is involved. So you can see it in multivessel disease. But then remember, sometimes in balanced ischemia where you have multivessel disease, you can see a global wall motion or global LV dysfunction. Now, also to make things a little bit complex, in dilated cardiomyopathy, which is not due to coronary artery disease, regional variation can be evident. The second complication of ischemia is LV aneurysm. LV aneurysm is a myocardial dilatation. You can see here there is a dilatation or outward bulge that is evident. You can see it in both in systole and in diastole. If you see it only in systole but not in diastole, then this is dyskinesis. Now, if you notice, you will see that this bulge, despite the wall here might be a little bit thin out, but it involves all the layers of the myocardium. And LV aneurysm is characterized by a wide neck. You can see the neck here is wide. Also, it is important to notice that LV aneurysm is a good place for LV thrombus. So here you have apical aneurysm or at least akinesis, no much of flow, stagnation of blood, and then you can see here a mural thrombus. That also will be discussed in the coming lectures of masses. Now also LV aneurysm can act as a dead space or a reservoir that does not contribute to ejection fraction. If you notice here, you will see that this lower part proximal to mid walls are contracting fairly well, and ejection fraction in this lower part is normal. However, if you calculate everything including that aneurysm, your ejection fraction might be maybe 35 to 40% max. Now, if patient has a clinical heart failure that does not improve with medication, maybe aneurysmectomy should be planned. Now, if you want to check for clinical benefit of aneurysmectomy, then you calculate the ejection fraction of this proximal to mid part, excluding the aneurysm. And if it is within normal range, you can predict a clinical benefit. Now, free wall rupture or pseudoaneurysm is a serious complication. Despite it is rare, but it is very serious. Now, it's a rupture. Now, if it is contained, like this one, it is contained here by epicardium, then it is a pseudoaneurysm. You will think it is an aneurysm, but actually no, it is not an aneurysm, it's a pseudoaneurysm. It has a short neck and it has a shelf-like structure here, or a shelf-like neck, and then the rest here is a thin wall only covered by epicardium. There is no myocardial tissue. Now, usually we see it with transmural myocardial infarction, and if it is not contained, it can cause cardiac tamponade and sudden cardiac death. Now, pseudoaneurysm can rupture anytime. Now, if you see it here, it can rupture anytime and cause bleeding everywhere. So once you see it, it has to go for surgical resection as soon as possible. Again, this is the same patient with pseudoaneurysm. You can see the short neck, the shelf-like neck, and a thin walled pseudoaneurysm that is covered with a thin epicardium. Now, adding color will make things more clear. Now, pseudoaneurysm is characterized by a to and fro flow. So flow will go to the pseudoaneurysm and coming back from the pseudoaneurysm. So you can see here there is a red flow and blue flow. And this is characteristic of a pseudoaneurysm that will help us also differentiate it from a true aneurysm. This is another example here of pseudoaneurysm. You can see it here. It is a pulsatile. It is in the basal area here, lateral area, pulsatile, and if we look in different angle, we will see the opening or the communication between the pseudoaneurysm and the LV. Now, same patient, when adding color and with little bit of angulation, you can see the short neck, you can see the flow to and from the pseudoaneurysm, and that communication shelf-like. You will see here all the characteristic of a pseudoaneurysm. Now, some features suggestive of pseudoaneurysm, as mentioned, a small neck. Now, ratio of neck diameter to maximal pseudoaneurysm is less than 0.5. For example, this is the LV. Now, let's say you have a bulging. Now, you check the neck here. This is the neck. You check the neck distance or diameter and compare it with the maximal diameter of the bulging, whether an aneurysm or pseudoaneurysm. If it is less than half of it, then it is suggestive of pseudoaneurysm. Also, the to and fro blood flow seen with color Doppler, it can be pulsatile, thin wall composed of pericardium and shelf-like edges at the neck. So here you can see the small neck, the shelf-like structure in the neck. There is red flow and there is a blue flow. So to and fro flow between the LV and the bulging or the pseudoaneurysm. Now, for every rule, there is an exception. So, for example, sometimes you can see wide neck. So it's not always a narrow or small neck. Sometimes you can see it maybe a little bit wideish. But if you look carefully here, you will see this shelf-like. So it's a shelf. It does not bulge gradually like this. No, there is a shelf. There is a shelf-like. And a lot of times you can see also thrombus. Don't mistake this thrombus or mural thrombus lining the wall here with a muscle or a myocardium. Here it's a shelf, it is clearly a shelf-like neck despite being little bit wide and thin pericardium, and there is a large thrombus can be seen within the pseudoaneurysm. Again, this is how we measure. This is a pseudoaneurysm. This is the neck, and this is the widest diameter. And here you can see this is a thrombus. Now, intramyocardial dissection or intramyocardial dissecting hematoma. It is a rare complication for sure of acute myocardial infarction. It can be seen with different etiology, for example, trauma. It is caused by a hemorrhagic dissection. So you will have a hematoma within the myocardium that will dissect the myocardium apart. Usually the hematoma is due to rupture of a capillary within the myocardium. Now, while maintaining the integrity of the epicardium, you can still see here the epicardium and endocardium. You can see it is, the integrity is maintained, but there is something here. Now, we will see this in the coming videos. This is example. You might think, okay, this is a thrombus here, but a careful look will show you that, okay, this is the endocardium that continues here. Now, I agree, totally agree that this is not a straightforward. However, if you do a short axis, then or a modified axis, you have to look in many angles. Then you might see a clear endocardium integrity. For example, you can see here the endocardium. See, you can see it, and there is a hematoma here that cuts this myocardium into half. So this part and this part sliced into half here. Look here, you will see it sliced into two parts. So this is myocardial dissection. Now shifting gears from ischemic complication of the LV to dilated cardiomyopathy. Now dilated cardiomyopathy has different etiologies, but usually it shares the same morphology, and the hallmark of dilated cardiomyopathy is of course dilated LV and systolic dysfunction, usually LV less than 40%. Etiologies can be idiopathic, familial cardiomyopathy. Sometimes non-compaction can cause dilated cardiomyopathy, maybe peripartum, hemochromatosis, infectious disease, post-viral myocarditis, maybe HIV related, and some toxins including chemotherapeutic medication like the anthracyclines. However, if there is ischemic etiology, then it will be ischemic cardiomyopathy. So this is an example of dilated cardiomyopathy. Now, LV dilatation, as we can clearly see here, is a prerequisite for the diagnosis of dilated cardiomyopathy. If you look carefully here, see the LV is very dilated. Now, dilatation can be mild, moderate, or severe. Also, typically, dilated cardiomyopathy has a global hypokinesis that also ranges from mild to severe. However, regional variation can occur, and the typical pattern will be preservation of the function of the basal, inferior, and infralateral wall. And here another example of dilated cardiomyopathy. Sometimes the RV will be involved, sometimes the RV will be completely normal. Here, as you can see, LV is dilated and there is a global systolic dysfunction. Sometimes, as mentioned, the basal inferior and infralateral wall can be normal. For example, here the basal infralateral wall contracts very well or thickens very well, so it is normal here. Now, also in dilated cardiomyopathy, there is the sphericity index, where you measure an end of diastole, the long axis of the LV from the apex all the way to the mitral annulus. See, this is the insertion of mitral valve, and this is the insertion. If we have a line here, insertion to insertion, then we measure this long axis, and also in the mid wall here you measure the short axis or the minor axis. Now, if the ratio, normal ratio, should be more than 1.6, now if it is 1.5 or less, this is abnormal. And the lower the sphericity index, the worse is the outcome and the more remodeling of the LV, and it can be also associated with mitral regurg, secondary or functional mitral regurgitation. Now, as mentioned, it's not only LV dilatation. If we think about dilated cardiomyopathy, it can be associated with functional MR, and we can see here severe functional MR. You can see it posteriorly directed MR jet here. Also, LA dilatation, pulmonary arterial hypertension can be present, and definitely diastolic dysfunction is always present. Shifting gear again now to LV non-compaction. So it is due to arrest of the myocardial maturation. Now you can see two distinctive myocardial layers, one compacted and one non-compacted layer. Now, if we see this non-compaction, we look at the function. If it is normal function, then we call it LV non-compaction phenocopy. Now, if there is systolic dysfunction, then this will be called non-compaction cardiomyopathy. This is an example of LV non-compaction. You can see here a lot of trabeculations. So this is all non-compacted layer, and you can see the compacted layer here and here. So you have two layers, and that will be more evident in the coming slides. Again, if we zoom here, you can see a lot of trabeculation here, which is all non-compaction. All this spongy shape myocardium is non-compacted layer. And we will see the criteria to diagnose non-compaction by echocardiography. In short axis, it's more evident. You can see all this spongy layer of non-compacted myocardium, and here the dense layer of compacted myocardium. Sometimes short axis will show us better. So you can see here, this is all non-compacted layer and small thin layer of compacted myocardium. In general, we have three echocardiographic criteria to diagnose non-compaction. The Jenny criteria or Zurich criteria, Chen criteria, or we call it California criteria, and Stolberger criteria, or the Vienna criteria. Now, for each criteria, we need to know which view we will utilize and which part of cardiac cycle. Now, in the Jenny criteria, It is the short axis at the level of LV apex, and it's at the end of systole. And the criteria says we need demonstration of two layers. You can see the non-compacted layer here and the compacted layer. Now the non-compacted layer to compacted layer ratio of this diameter is more than 2. So if this non-compacted is double of this compacted layer at end of systole, short axis at the apex, then this is a positive echocardiographic criteria for non-compaction. Now, Chen criteria, again, it's parasternal short axis, maybe mid to apex. It is at end of diastole. And then again, we have to demonstrate two layers, one thin compacted and one non-compacted. Now, non-compacted layer along with the compacted layer should be more than double, or this compacted layer is less than half of everything, compacted and non-compacted. So if the compacted is less than half, then this is a positive criteria for non-compaction. Again, it is at end of diastole. Now, Stolberger criteria is apical views. So we utilize any apical view, any part of cardiac cycle, and what we need to demonstrate is 4 protrusions or trabeculation distal to the papillary muscle. So if this is the papillary muscle, distal to it, we have to demonstrate 1, 2, 3, 4, and here 5. So 4 and more protrusions or trabeculation in a single plane, single shot, any part of cardiac cycle, apical view, distal to the papillary muscle is consistent with myocardial non-compaction. Now we have some tips and differential diagnosis. Now, non-compaction is often regional. It involves the apical and lateral wall most often. Now, color Doppler can be helpful. Ultrasound enhancing agent also helpful to visualize the flow within the recesses. Now, excessive trabeculation not meeting the criteria, you only see a lot of trabeculation, we call it excessive trabeculation. We don't call it non-compaction, but we describe it as excessive trabeculation. Now, trabeculation also can be seen in dilated cardiomyopathy, in anything with volume overload. Sometimes pregnancy, we can see some excessive trabeculation. Now, mimickers, for example, apical HOCM can mimic, thrombus can mimic, particularly if it is an old resolving thrombus, eosinophilic heart disease, endomyocardial fibrosis, all are mimickers of non-compaction cardiomyopathy. So this is an example where you can see there is a non-compacted layer utilizing the echo contrast or ultrasound enhancing agent. So it can help us to see non-compacted layer versus the dense compacted layer here. Also in short axis, very clear. This is, you see LV systolic dysfunction. You can see this is all non-compacted layer and small thin compacted layer. So this is LV non-compaction cardiomyopathy. I will stop here. Next lecture is a continuation of LV pathologies and it's part 2. We will talk about Takotsubo cardiomyopathy, restrictive cardiomyopathy, hypertrophic, obstructive and non-obstructive cardiomyopathy, and cancer therapeutic induced cardiomyopathy.